Begin this afternoon with the presentation from the Department of Health. So, thank you. And we have commissioners, and we're happy to turn it over to you. I think, did we go around the room and introduce ourselves? Okay, so we don't need to know us twice. So let's go ahead and start.
Reinforcement doesn't hurt. So I'm Dr. Mark Levine. I'm Commissioner of Health. I'm accompanied today by my Financial Director, Paul Daly. And on the screen, Deputy Commissioner Kelly Docker.
Good afternoon, everyone. I apologize. I'm not there in person. I am keeping some germs to myself today.
There are plenty to go around in this building. Because this is really our first presentation of our budget, other than what we did in the BAA, we thought we'd spend a few moments just acquainting you with the department and giving you an understanding of the breadth of what it does. That doesn't have to be a lengthy part, but I want to make sure everybody's sort of got the same foundation. Then we'll move into our budget, which has, as always, 3 appropriations: administration and support, public health, and substance use. And in that part of the presentation, we'll do a little bit of tag teaming, where financial director will go through some of the ups and downs, and I'll go through some of the actual meatier proposals. So, who's controlling? I am. Okay, thank you. The middle of the slide shows mission of the Department of Health. And I'll just give you a moment to read that. But the bottom line is that sort of encompasses everything about us. I still think in this day and age, if you look at the bottom of the slide, our leading value is equity. And you'll hear a little more about that. Today, we're going to use language like that.
Like singing harmony there too.
Yes, we need more of that.
Sing the sing.
What the world needs now. Yes. We thought we'd define public health. And public health basically differentiating it from health care and differentiating the care of individuals, which is what we do in healthcare all the time, from populations. But the 3 sort of foundational aspects of public health, what I like to call public health 1.0, is really combating and preventing epidemics of infectious disease, working on environmental health threats, and trying to promote a healthy lifestyle to prevent the development of chronic disease. Those are very foundational. They're the foundation that builds on Public Health 2.0, which is really looking more at the health-related social needs of population. So you hear statements like housing is healthcare, and it truly is. And unless we pay attention to those needs, whether it be financial, economic, housing, food security, et cetera, we won't really be getting at how to help the population. And then 3.0 is what's on the slide, which is health equity. And health equity, really, for the sake of definition, is having the same opportunity to enjoy good health. And generally, when populations don't enjoy that opportunity, it's due to historical injustices, discrimination, bias, things of that sort. Practically speaking, what you see in front of you is called the healthcare pyramid. Things at the top are much more individual focused. Things at the bottom are much more population focused. And it's not that some are better or worse. It's just this is the portfolio of what there is in terms of the impact that they have. So as a practicing physician, most of my life was spent on the top 3 parts of the pyramid. a lot of counseling, which eventually, with education, got people to adopt better habits. Not overnight, sometimes over decades. Second rung, clinical interventions, is really treating all of the chronic diseases somebody trained in internal medicine does every day. And then the third rung is really in the health maintenance or prevention arena, where we're trying to make people stay healthy by screening for cancers, cardiovascular disease, using immunizations, etc. Public health really dwells much more on the bottom two parts. And one of them, as you see, is called changing the context to make individuals' default decisions healthy. What that essentially means is policies and other programs that allow people to make the right choice, or perhaps the wrong choice is no longer available or more difficult to achieve. So when we've passed policies that increase taxes on cigarettes, when we prevented people from smoking in public places and prevented people from getting secondhand smoke, when we work on our lead programs, et cetera, all of these things really create a healthier place as a starting point so people can continue to build on that. You can't buy a box of crackers anymore that has trans fat in it because we know how bad those are for you. Still buy plenty of bad things. And then on the bottom part is really addressing those social determinants, access to wealth, education, and making sure that we work on health disparities. I'm not going to read all of the things on this slide. This is really just to introduce you to things that you'll recognize in your day-to-day life or existence here in Vermont. These are things that the health department is doing. We like to say that if you don't know the health department was doing it, we probably succeeded in our mission because we're really behind the scenes. And we don't need to get out there and brag about a lot of things most of the time, as long as these things are happening in our communities across the state. I'll introduce you to the department now. As you can see, there are 8 divisions that are portrayed here, and they all stand on that foundation of health equity. And I'll just go through one by one with some examples of each, the kinds of things that go on in the Department of Health. So, and this is not in a priority order by any means. Starting with environmental health, obviously we all recognize there are environmental threats out there all the time. And we have programs like lead programs in housing in terms of paint and protecting our youngest citizens. Lead programs like we worked on with the legislature, preventing lead from being in the school drinking water. A whole host of climate-related initiatives, some of which involve food and water safety, some of which involve cyanobacteria, respiratory health, the list goes on. And then some familiar things to people in the legislature, PFAS in our drinking water and PCBs in the air in our schools.
Okay.
You want to ask a question?
I'm going to ignore the fact that the chair walked in and ask my question.
Go for it.
How do you divide up the responsibilities on some of these areas with the Agency of Natural Resources? When we think of, environmental health issues, air quality, I think of A&R.
Yes. So the Department of Environmental Conservation, which is part of them, we are very much yoked together with much of the time. They are the regulatory arm. So when you figure out what's in the water, their job is to regulate and make sure that water systems are complying. They operate on the basis of understanding the health impacts, which we provide. And we do a lot of joint programming to help mitigate a lot of these situations, both testing and mitigation. It's a very close relationship.
I guess I'm concerned with the duplication of efforts.
Yeah, it's really complementary.
Thank you.
Moving.
Wait a second. One moment, we have a, thank you. Rep LaRouche is online, hasn't he?
I had just asked you to come in.
You can't see that?
Well, no, it's. Yeah.
Anyway, Rep LaRouche, go ahead.
So on the PCBs in school air, my understanding is that the level of PCBs in school air, the limit is far less than the EPA standard for PCBs in school air. Did your agency set that limit? Did A&R set that limit, or is something that's set in statute?
No, we were part of the development of those limits through toxicology research and being informed and consulting across the country. But what policies we've enacted in the schools across Vermont, A&R, AOE, and the Department of Health are all in sync, aligned with that. There's a whole host of reasons why the levels from the EPA are different than ours, which is a whole other talk. And I provided that testimony each year for the last several years in front of the education committees.
So you had better science than EPA.
We have more up-to-date science than the EPA, and we actually have the EPA, I'll use the word aligning with the levels we've come out with. It's just that it takes the federal bureaucracy a lot longer to turn the ship than it does for us.
Thank you.
Thanks, Wayne.
We'll move on to family and child health, which is exactly what it says. And it's across a continuum from the pregnant mother through the early days of an infant, through adolescence, and through life. And bottom line is a lot of school health programming, important programming at the very beginning of life, like home visiting programs with nurse practitioners and family specialists. And then the WIC program, which is very well known to everyone in the legislature. Moving on. Laboratory sciences and infectious disease, you'll often referred to as EPI. But the goal is, of course, monitoring and preventing the spread of infectious diseases. Some of them familiar to you, like the respiratory diseases. Some of them a little less familiar, like some of the food and waterborne diseases. And some that are very unique to Vermont in many ways. Well, not unique, but prominent in Vermont in many ways, like vector-borne through ticks and mosquitoes. Our whole immunization program is in this category, and we have an entire public health lab that is part of this division.
I have a question on this. Thanks, Dr. Levine. I'm wondering, I've been reading that the CDC isn't allowed to talk to the World Health Organization, and maybe not to you. Has the information flow between Washington and Vermont stopped around this kind of stuff?
There is parts of the information flow that is not going well. It's not in this area.
Oh, okay.
In fact, all state health officials were on a call yesterday with a high-ranking member of the CDC who was discussing an Ebola epidemic in Uganda, which could very well have implications to air travel to this country and what state health departments need to do. And that was incredibly timely. It was right when we would expect it. And all the staff in this division have close connections with CDC personnel that are not interrupted. Things that are interrupted are another category.
Okay. Well, I hope you will point them out so we're just aware of what.
Yeah, some of them have to do with grants. Some of them have to do with the types of communications and messaging. But they have not impacted us heavily in terms of doing our job in public
In this
health.
area. Okay. Right. All right. Thank you.
Substance use programs is another familiar category. We like to talk about a continuum in substance use, going from prevention to intervention to treatment to recovery. And all of those are sort of under the rubric of what this division does. I always have to lead with alcohol because it's the forgotten stepchild when everyone's worried about overdoses and opioids, as they should be. But in terms of balancing things out, alcohol is and will always probably be the number one substance use problem. There's also a close connection with tobacco in terms of nicotine priming the brain. There's another division that is much more focused on tobacco than the substance use division is, but they're closely aligned. We have local health offices.
Question, oh, right, replicas.
Thank you. So you have alcohol and tobacco, pretty common things that we knew were no good. And now we have cannabis,
Pretty common now too.
more common all the time. So where is cannabis? It's not in the Department of Health. Where did
Oh,
they
no,
do it? It is here.
It's right there.
Okay, so it's under this program.
It is.
Okay,
It's not listed prominently, but it's.
but it's there. Okay, so I need to know. Thank you.
And, there's many drugs that aren't commonly talked about, but they're still there, like
Right.
stimulant.
Thank you.
We are a centralized health department and have 12 district offices, but they are all part of the centralized department, so they're not independent local departments like many larger states have. So the boots on the ground in Vermont happens at the local health level. You can see where they are based on the map. They're pretty evenly distributed, and things like clinics for nutrition, like WIC, vaccination clinics, et cetera, occur there, as well as really that frontline community connection. Health promotion and disease prevention is a,
Pause you for 1 second, Dr. I think Rep. LaRouche has another question. Is that a new hand?
Yes, that's a new hand. I'm a little
Okay.
late. I'm a little behind the curve, but it was back after with Rep. Dickinson's question. We just had testimony this morning that 80 to 90% of the mental health patients that we have addiction problems, and I know from being on the corrections institution committee that's about the same number of people in our prison system have those same kind of addictions, and so I'm a little baffled that doesn't seem to be a high priority on your list. I mean, again, we see all these anti-smoking campaigns, but we don't see that normally on our TV commercials or anything like that. So, is it being downplayed?
you're saying is it the cannabis, or are you talking about something different?
I'm talking cannabis. I'm talking all the drug.
Any addicting substance?
Yes.
Yeah, okay, so I pointed this out, I think, at the BAA testimony we had here. And the bottom line was there are target audiences for all of our messaging, and much of the messaging is youth directed. Youth may be middle school, high school, or what I'll call young adult, 20 to 25 year range. And the kind of media that youth is accessing is where this messaging comes through. So you may not see it on a television ad like you do the tobacco ads, but it is present still. It's just not focused on you yourself or most adults.
So do you have any indication of success or failure in that campaign?
Yeah, we measure success by sort of uptake of the messaging that we do. And we use youth to actually inform the messaging as well and see their engagement. So the main way we would be able to judge the success is through like youth risk behavior surveys and other survey data that we have. And there's clear indications that when you invest in some of the prevention money, like the prevention coalitions, the prevention school programs, and the messaging, that you can, if you do that in a sustained way, see decrements in youth uptake of tobacco products, alcohol, and cannabis. The one that seems to be operating on its own now, the tobacco and alcohol seem to go in the same direction. Sometimes more recent years, the cannabis is going on its own a little higher.
So no decrease or any signs of decrease of people in emergency rooms with these kind of issues or in mental health, asking for mental health care?
There's a raging epidemic for substance use and mental health that's not just related to how successful or not we are with our messaging. It has to do with the pandemic and the post-pandemic world we're living in. That's all I can say.
Thank you.
And then, you know, the rates, you mentioned 80, 90%. We don't really know the number, but we think that large parts of the population with substance use and mental health are the same population. They have co-occurring disorders. 70% is one number I'm more comfortable with, but that's still a very high number. And the number of people in our correction system that are on medication for opioid use disorder is in the 60 to 70% range, sometimes lower towards 50, sometimes higher towards 70, but in that range. Last but not least, I think, well, not last, but emergency prepared, health promotion, disease prevention. Yeah. That's where tobacco control programs are. That's where chronic disease prevention is. All of our new efforts with healthy aging, so-called Age Strong Vermont, in conjunction with Dale, is in this arena. And it's a very important part. Traditionally, not a huge source of federal funds, unfortunately, which is tough for me because I'm an internal medicine doctor and this is what I preached all the time, but I wanted to even have more of an impact on in public health. But that may change depending on certain nominees being accepted or not. Who knows? Emergency preparedness and injury prevention. We have tremendous amount of disaster response training, pandemic response. So everybody knows COVID. We've had many environmental disasters in Vermont. This part of our operation is really front and center during those times. And other infectious kinds of things besides COVID that don't make the news as much, we also often need to utilize our emergency preparedness capacity. They also have injury prevention as part of the name of the division. So suicide prevention is a big part of that, but falls prevention, there's a whole host of other injuries, child seats and restraints in vehicles, etc. Then finally,
We have one question here, Representative.
I just want to go back real quick. I just have a question about diabetes. What you're kind of seeing statewide for, is it increasing, leveling off, decreasing? And
it's gone up a little bit. I think prevalence in Vermont is in the 8 or 9% range. So with obesity being a major national problem, we are still in the set of states that's in the lowest gain in that regard. However, we still have it everywhere else.
are you seeing more people using some of the technology to better self-manage kind of where they are? Dexcom?
Yes,
Yeah.
for sure.
And I asked,
That's
I
sort of,
have some friends who are using that technology.
yeah, that's modern times.
Themselves and
Yeah,
That's emergency situations.
right.
Thank you.
And floods is just an example. And then last division is every good health department has to have tremendous data. And here we have an entire division related to all of our data, whether it's vital records or registries or survey data. This is where we have our credibility. We come to committees like this and we use the data we have to show you why we're doing or want to do what we're doing.
Dr. Levine, this is really helpful, and I'm wondering, what programs you have you feel are especially successful, where you see some challenges? I'm sure, I'm hoping that, I mean, we'll go through the ups and downs, but, sort of where you'd like to expand things, where you would modify things, what's your thinking about here?
Yeah, okay, so we'll talk a lot about substance use.
Yeah.
But there's a lot of success in substance use, but there's always room for more work. And you'll see that during our presentation. I already mentioned in the chronic disease prevention arena, we do as much as we can do with the federal grant money we have. But more would always be better because 80 cents on the dollar, give or take, for healthcare spending is chronic disease management. So why have so many chronic diseases if there are ways to help prevent them? With our maternal child health and youth prevention, I think we're doing really well in many, many of those areas. We can always do better, but trying to really help, especially our most vulnerable families at times in life that are most stressful, like when a newborn comes into the world or during that pregnancy. A lot of good programming there. Always could be more robust. In the environmental health arena, I think, we're a state that's very progressive in this arena. So a lot of success, but a lot of vulnerability because of the world we're living in right now. And just looking at the floods repetitively in Vermont recently, other aspects of climate change, this is a national phenomenon that health departments literally have this much funding for that. Everyone's focused on, how many electric cars we can have, but they've lost sight of the fact that this is a public health issue. And the reason we care about electric cars is we need to live on the planet in a healthy way. So we have over 600 FTEs in the Department of Health. 1.3 are dedicated to climate change. That's not your fault. That's a national phenomenon. So that's a little, I don't want to skirt over your question, but that's sort of gives you a little bit of the landscape. And with that quote, we'll move on to the budget. So this is sort of your overall summary slide, giving you an idea about where our funds come from. $226 million is our total budget across the three appropriations. That is $11 million higher than fiscal year 2025. So it's a 5.2% increase. You'll notice a huge yellow part of the pie chart, which is federal funds, and the almost equally huge light blue part, which is the global commitment line. So there's a lot of federal component to our department's budget. The dark blue shows the true general fund aspect, which is not large, but is significant still.
What's your special fund?
So special fund is a big chunk of that is our immunization fund, but there's also a few other components.
The health department has about 24 special fund appropriations, and from very small to very large. And we directly collect about 70% of our special fund appropriations through things that might be obvious, like restaurant licenses or physician licenses, but also the health department collects the legislatively mandated fee for pharmaceutical manufacturers and labelers that provides the source of revenue for the evidence-based education and advertising fund. And as Dr. Levine noted, we operate a Vermont vaccine purchasing program, which we'll talk about in the ups and downs, that assesses the insurers in the state for the cost of buying at federal rates the required immunizations and providing them at no charge to providers. That alone is over $10 million.
I'm sorry, go ahead. I'm looking at you to call on me, Chair. The opioid settlement fund, is that also included?
One of them, yes. Yeah, it is one of the special.
Yes, yeah.
And you'll hear some wrinkles about that further in our presentation.
Okay.
If I could add, Representative Blumley, when you see what we're presenting here, this is our base budget. Most of the appropriations that have been made to date from the opioid abatement settlement fund have been made as one-time appropriations. So in most cases, they would not appear in our base budget.
Yes.
What you see today is going to include $6.5 million funding for new activities. And those will become clear towards the end. So bottom line number one is current service budget is fully funded. Secondly, the recommended appropriation for substance misuse prevention programming funded by the cannabis excise tax is going to be increasing by 125%. And thirdly, the budget is going to recommend $2.8 million in new funding for substance use disorder treatment and recovery. And we will go through the details of each of these as we move on. I will now gain some help with the ups and downs from Mr. Dale.
The members can find this section of the ups and downs in our presentation, but if you're using the AHS ups and downs, it would be we are on page 11 and 12 and 13 of the AHS ups and downs. And as we'll start with the administration and support appropriation. The first line in the yellow shaded section is a change made after the legislature adopted the fiscal year 25 budget. In fiscal year 24, $250,000 was appropriated to the agency of administration to fund 2 positions for a new office of health equity. That office has been established in the health department, and the positions have been transferred from the agency of administration. And our 26 base budget includes continued funding for the office. Already had a few departments from AHS in, so the personal service line changes will be familiar to you. They represent the net changes in budget amounts for salary and fringe benefits right across the sources of funding. And from all of those lines down through child care contribution are those fringe benefits are a function of salary. The workers' compensation insurance premium is an internal service fund charge that we get from the agency of administration. That entire premium is funded in the administration budget. And the last item in personal services major object is vacancy turnover. So in this appropriation and in our other 2 appropriations, we assume a vacancy rate of 2%.
What percent?
3%.
What do you, sorry,
Vacancy.
I know, I'm sorry, I didn't raise my hand.
Go ahead.
What are you experiencing right now? I mean, is that higher or lower than what you have experienced, say, for the past year?
Our vacancy rate has been trending downward in the last 2 fiscal years pretty substantially. It peaked for 2 reasons during the pandemic. It peaked because we were losing a lot of staff because of the stress of the pandemic response. At the same time, new positions were being established. So we had new positions we're recruiting for, as well as high turnover. As the COVID era supplemental funding and activity wound down, our overall position count has trended downward. And we have seen a fairly high retention rate. We have not seen high rate of turnover. It's really turned around. So 3% is about where we are right now. We were as high as 11% at the peak of the pandemic on an average, but we've been under 8% for the last 2 fiscal years.
That's actually very good, because in the past 2 years, it's not just the health department, but statewide, there's been a lot of challenges with, and that number has been going up, sometimes for budgetary reasons. Thank you.
We've avoided that this year. Operating expenses. The change here, these are all internal service charges. And the biggest single change is that it reflects the reduction in rent charges that we paid when we were at our Cherry Street office in Burlington. We moved in the 4th quarter of fiscal year 24. What you see on the second line, the fee for space charge, is the offsetting increase. Our occupancy charges at the Waterbury State Office Complex are accounted for in the internal service process as a fee for space charge rather than rent, as we did at Cherry Street. You'll see minor changes in rent in the other 2 appropriations as well because of the way we allocate. We allocated the rent at Cherry Street based on head count. really moved into a primarily telework arrangement now. So the cost of the fee for space charge is borne entirely in the admin appropriation.
We're pretty clear on, personal services operating expenses, they're kind of standard throughout. So unless there's something dramatically different that we should know about, we can probably skip those pieces and go to the meat of whatever the ups and downs
I'm
are.
happy to do that, Madam Chair.
Unless anybody has any questions as we go. I see that vacancy savings in 312 is a pretty high number.
That's because over 500 of our total staff are employed in public health appropriation. It's still 3%.
So we're now on the public health appropriation, which is 58% of our budget. And other than programs in substance use prevention, treatment, and recovery, it funds most of the other public health programs we have. So I guess we will jump to the grant major object. Is that what you intended, Chair?
So,
Page 24 of our presentation.
okay, yes. Section B 312 with grants. Yeah.
Yeah. Okay. So,
Madam Chair, your hand.
Oh, we have another here. Thank you. I do not see it. Rep. LaRouche.
I'd just like to ask the move from Cherry Street, was that a net, did you end up with a net improvement or worsening in terms of budget with that move being made? Did it cost you more or did it cost you less?
It was a net savings. The savings were offset in part because Cherry Street was also the home of our district office. And that district office has relocated to a building in the lakeside area of Burlington at a considerably higher cost. It's a much newer building. It's more spacious. It has better security, but it's much more expensive. So those are our savings from the move in terms of our central office were significant in the range of several $100,000 in state funds. But there was an offsetting expense with the new cost for the district office.
Thanks, that's excellent.
okay, we'll move to what was promised, which is the first line immunization program, which that budget account includes most of the cost of the immunization program. And included is the state's vaccine purchasing program. And the cost increases you're going to see are related to that program. And so for context, Vermont is a universal vaccine state. We have what's called the Vermont Vaccine Purchasing Program, which purchases these vaccines from the CDC directly, and that's through a federal contract. And it supplies them at no charge to providers across the state for use in all kids and in all adults who are under the age of 65. The program itself is funded through fees that are assessed to health insurers who cover Vermont lives. In 2009, the Federal Assembly actually authorized this program on a pilot basis, and it became permanent several years later. It's a real public health win. It's an important factor in our success in achieving and maintaining high rates of immunization against vaccine preventable diseases. If you look at the 2023-2024 school year, 94% of Vermont's K through 12 students were fully immunized in that year. We've also, in the last decade, been able to extend coverage to some of the recommended adult vaccines like influenza, shingles, and COVID.
Great. We have a question here.
So I know a lot of this comes out of special fund, but do we get any federal help with cost?
Yeah, all I want to say is we're getting a bargain rate compared to not purchasing the way we're purchasing them.
Purchasing from the CDC, that's the.
Right.
That's the help, I guess.
He understands what you want. I just had a.
I don't want to be an alarmist, but fortunately,
It's been on our mind, Representative.
maybe
Vulnerability.
vulnerability there. And It is what it is, but I'm just curious as to how exposed we are in this area, because I would hope that we continue to do whatever we can to encourage and perform vaccinations where it makes sense, which is a lot of the traditional long established protocols. You mentioned polio and, you know, certainly measles and another area, so.
Representative Harrison, we do get significant federal support, direct in the form of federal immunization grants that pay most of the staff who work in our program. And also we get direct in-kind support. The Vaccine for Children's program provides vaccine for all children on Medicaid at no cost to the state. And so
We don't even pay our typical 43% on that.
that's correct. That's correct. The charges to the Medicaid program for the vaccine purchasing program are all in the adult Medicaid population. And again, we're able to buy at the federal contract rate to save the Medicaid program money.
Rick Dickens.
Okay, so the immunization program is for all children and adults under 65. What happens to those over 65? Is that billed out to Medicare?
Yes.
Yes.
So you get paid that in addition to whatever Medicaid and the other things that go into,
I'm not sure if I understood your question.
Okay.
Representative Dixon.
it's free because you get the money from pharmaceutical companies. Correct, the fees?
We don't, the program
We
does
don't
not provide
provide-
vaccine at no charge to adults 65 and older. So if
You
if
do
you're,
provide it, yes, so Medicare pays for that.
No,
No.
we don't.
Okay, I'm gonna go back.
the program doesn't extend to folks
Over
65 or
65.
older. Right. So Dr. Levine and I are not beneficiaries of the program any longer.
It comes out. You're not the only ones.
But the issue is that people over 65 don't get vaccinations and are encouraged to get vaccinations.
Yes.
And that is paid by somebody. Is that-
Medicare.
They bill that to Medicare.
It's 100%.
So you guys would be charged to Medicare and they would pay whatever the state does.
That's correct.
Okay.
And it's actually been a considerable issue for a long time in several states besides Vermont run vaccine purchasing programs. And Medicare has refused to participate as a covered insurer. And the states continue to have dialogue with the federal government in the hopes of doing that. The program would be more effective if it covered the entire population.
Right. CMS is,
And stay tuned for, in future years, you may hear more movement on that front.
right, okay, thank you.
And if you're an insurer, the insurer is paying less for the cost of these vaccines. Because of the high rate of vaccination in Vermont, there's less healthcare consequences of not being vaccinated. So they are winning in
Yes.
several ways.
Okay, I'm gonna ask a second question here. You got $770,000 under Medicaid general global commitment. That comes, you said that Medicaid doesn't pay for this.
Medicare doesn't.
Medicare, but Medicaid kicks into this as well as,
Well, in the Medicaid program in Vermont is considered an insurer subject to the assessment based on covered lives.
right,
So the program, Medicaid pays an assessment for adults on Medicaid, those folks who don't get their vaccine provided through the Vaccine for Children program. And we administer that in our budget. So this is,
so that's where the 770,000.
this is the amount of increase.
Okay.
And it's a pretty substantial increase, due in large part to the addition of the shingles vaccine and the COVID vaccine to the adult Medicaid population.
Okay, thank you.
So is the 1.8 million an increase over, or is it this like the grant renews each year, so you have to put it in? I mean, is that an actual up, the 1.8 million?
They're both ups, Representative.
Okay.
The total vaccine program,
It's 15.7 million.
thank you.
Oh my, thank you. Okay.
So you've actually asked the questions of things I was going to tell you.
Oh,
So I think we're done with immunization, if everyone's done with immunization.
I think we're good on that line. All right.
Okay. So the next line is Advanced Directive Registry. I don't know how many members of this committee that those words sound familiar, but it's Vermont law that this department maintains this registry. And we have a contract with Vermont Ethics, a grant to the Vermont Ethics Network. And they have a contract with a registry provider, the American Living Will Registry, for customer service and administrative support. So the fiscal year 2026 budget is $435,000 for that program. Costs have increased because of increased fees and reduced customer service from that American Living Will Registry, so that the Vermont Ethics Network has to commit more staff time to the activity. So we're just keeping the program operating at the cost that it now is. Final line in this public health appropriation is a special fund reduction. This is an interface with the opioid abatement fund, actually, of $1,050,000. And that's for grants to support syringe service programs. So the health department's required through the statutory authority for the special fund to submit an annual spending plan to the General Assembly, informed by the recommendations of the Opioid Settlement Advisory Committee. And the chair may recall receiving my letter in the early part of January. Given that this requirement for a specific spending plan has got to be approved by the General Assembly, we don't include this appropriation in the fiscal year 2026 recommended base appropriation. The administration and the legislative leadership have agreed to consider this year's recommendations for appropriation from this special fund as a separate bill this time around, considered initially by the committees of jurisdiction before being referred to the Appropriations Committee. So that's sort of the new wrinkle in the process this year.
Okay, we'll look for a separate bill.
Now, our recommendation for the fiscal, I just finished one thing because it may have.
I'm sorry, go ahead.
The recommendation for fiscal year 2026 includes continued funding for the syringe service program at the same level that I described before. And that's because last year it was quite clear that the General Assembly's stated intent was to provide ongoing funding for this syringe service activity from the special fund for opioid abatement, provided funds remained available, which they do.
Thank you, but no, go
I'm reading the language section, of the FY 26 budget. And the language is markedly different from the language in FY 25. In years and years and years worth of budgets, you've spelled out the syringe service providers who receive an initial 295 or something. And then, anyway, this seems to open the door to many more providers. Given the language that says, it doesn't name any of the syringe, traditional syringe service providers. And there does seem to be a reduction in the amount of money. And this is something that, I can go over more closely with you all, but I am wondering, I think maybe the most useful question to ask right now is what's the purpose in expanding the universe and not naming any of those organizations?
Representative Boone, the total dollars for general funding for I'm assuming you're referring to section E312.
Yes.
The total funding is unchanged from fiscal year 25. There's a minor rewording because the total of 695 for harm reduction services was previously in two different subsections of that. It's just been combined from a language perspective. And This is with that one change, exactly the language that we proposed in last year's budget.
Well, why don't I get back to you on that?
Oh, sure.
Because I'm reading this differently and I
Yeah.
just may not be understanding.
And I can tell you, there has been no intent to increase the number of syringe service providers. I think we're lucky to have the ones we have, and
I know,
though they may expand their region or, have more mobile capacity than they had previously, I don't think we're seeing new providers.
okay, it just the language. We will talk about.
Okay, yeah, all right.
And Rep. LaRouche has a question, I see. Wayne?
Yeah, what do these providers do? I'm sort of naive, I guess, on this particular service. What's their function?
Yeah, so a syringe service provider, the more common term that's used outside of rooms like this is needle exchange. So the opportunity for someone who's actively using intravenous drugs to bring syringes, needles back, to get new ones that are sterile and clean, to get harm reduction counseling as well as education about other things they can do to keep themselves safe. A big priority in developing these in the first place was prevention of infectious diseases like HIV, hepatitis B and C. And they have actually, that's a big part of their success. And so they really started out as infection disease prevention programs more than traditional substance use programs, if you will. Now there's a tremendous harm reduction focus of them. There's an opportunity for clients to, with just saying the word, get engaged in treatment, often at the same site, or at least be escorted to a site right away that they can get their first dosage of medication for opioid use disorder. So they're very important, trusted community for those who are using intravenous drugs.
Thank you.
Are we done with the public health department?
Oh, nope, Rep. Harrison, sorry. Thank you.
So,
I'm not rushing you. Please.
getting back to the opioid fund. It seems to me last year we paid for the safe injection site out of that fund.
Yes.
Is that an ongoing expense out of that fund? And if so, will it be part of the bill or legislation that you were referring to
It's an
earlier?
ongoing expense. It was listed as should the funds remain available to be renewed on a year-by-year basis. That's what the legislative intent was. In our recommendation letter, we recognize that and sign off on that, if you will, for this year's recommendations. So not only are there a whole set of perhaps 17 recommendations for new programs, there are several programs that had this legislative intent stated last year that we agreed should go into the fund for the next year.
Thank you.
So that brings us to our last appropriation, which is substance use. And Madam Chair, would you like us to go straight to grants major?
I think so, unless there's anything more that's
I don't
not
think there's any,
business as usual.
nothing novel.
So let's just go on to the good stuff. Thanks.
Okay, so the first item you'll see is an adjustment in the split between global commitment program and global commitment investment. The budget bill does not make a distinction between the global commitment spent Medicaid program and the global commitment fund spent on Medicaid investments that are authorized under the global commitment for health waiver with the federal government. The ups and downs form used by AHS does show program and investment in separate columns. So this change on the ups and down form reflects the fact that slightly more of our GC funding is on the investment side and less on fee-for-service treatment payments. it doesn't reflect the change in current service program spending. So I'll move to the next item.
Which line are you on? You were just talking about this overall?
It says rebase.
Okay, the rebase one. Okay, got it. I was looking at okay. For the next line.
Yeah, so now I'm on the substance
Okay.
abuse prevention, change in cannabis revenue funding line. The governor's budget recommends replacing the current $3 million general fund appropriation for substance misuse prevention program, which we've had for several years now, with a $6.75 million amount from a new substance misuse prevention special fund. Section 312.4 of the executive budget language has the statutory changes required to establish the new fund. And Deputy Finance Commissioner Merrill explained the reason for this change in his testimony on January 28th. This is really, from our standpoint in public health, really good news because it doesn't really matter what fund it comes as. For the past 2 decades, we've used time-limited federal prevention funding to establish programs in some communities and learn what works and how to make and help programs make a difference. We've been able to look at the results. We've been able to apply what we've learned to improve outcomes. With a stable long-term funding source that conceivably could reach $10 million annually, we can then support programs in every community, scaling it up appropriately across the state and meet each community where they are in terms of readiness. So this is the success of the cannabis initiative.
If I could just interject quickly, the opioid special fund, how does that recently released announcement from the AG's office about whatever it is, and I don't know if that was the same money just up front instead of 18 years, and so does it change anything that you have available now?
Right. So to my knowledge, we don't have that money in our treasury right now. None of our recommendations that we made even dreamt of that money being available because it happened very recently.
Right.
But that is the Sackler family / Purdue Pharmaceutical money. $22 million in a lump sum to the state of Vermont. Prior to the Supreme Court ruling and prior agreements that the family had reached, we were supposed to receive $3 million per year times 18 years. So the math there is $54 million. This is the new agreement that's not just pertinent to Vermont.
Agreement worth more money though.
Well, but the old agreement is out the window because of litigation. So a new agreement had to be arrived at. I'm not going to go, I'm not the AG's office, so I'm not going into detail on that.
That's fine.
But it is a $22 million lump sum that will come to the state.
Extra pot of money, but it's not. It's replacing the other money you were getting ongoing.
That we never got, but that we could have got.
Good, okay.
Right, there was gonna be,
All right, I'm confused
Bird in
myself
hand.
now. So,
Yeah, okay.
Everyone thought that Purdue Pharmaceutical money was going to be the first money every state saw. And in terms of timing, it's the last money that we're seeing.
Okay.
But we've had plenty of other contributors to the fund. Okay. There's another line that you'll see, which is bookkeeping issue,
I can take
which
the
he can
last three
take
there.
that really quick.
On the grants major object, account code 602912 is a correcting entry. There was an appropriation made in fiscal year 25, and it was appropriated at personal services major object, and this is just, so you'll see a down in personal services and an up here. And the second one next to that is Similar to public health, there was a base appropriation made from the opioid abatement special fund to cut for recovery housing. That's not in the base, but it is in the governor's recommendations for use of the fund fiscal year 26. And the last item before we turn to the initiatives is something you heard from mental health this morning on. This is the offsetting. This is where we're transferring funds to them for their new pilot project for certified community behavioral health clinics.
So that brings us to our new initiatives, and I'd like to invite Deputy Commissioner Doherty, who you met on the screen an hour ago, to present that briefly.
Sure. Good afternoon, everyone. So we do have some new initiatives in the substance use appropriation for FY26. The first one, as you can see, is $1 million for what we are calling re-engagement beds or stabilization beds. And the purpose of these beds is twofold. One, if someone is living in recovery housing, so like a sober living environment, and they need to be exited because of either substance use or other behaviors that are endangering the welfare of other residents, we will have these beds that folks can go to until they stabilize and can return to the recovery living environment. So those would be based at our existing residential treatment facilities. So sort of repurposing some beds for that purpose. The other way that those beds can be used is if someone is getting ready to leave residential treatment, but they're awaiting a bed in a recovery house or sober living environment, they can stay in these beds until that placement becomes available. The second piece is what we're calling aftercare navigators. So currently, when folks are in residential treatment for substance use disorders, they do have sort of a treatment plan that is developed while they're in residential treatment for their follow-up care, whether that's engaging with the hub and spoke system or outpatient treatment or intensive outpatient treatment. What we're lacking, though, is assistance in sort of operationalizing that aftercare plan. So folks sort of have a plan in hand, but they may not have, the resources or the wherewithal to navigate the system on their own. So what we're proposing is hiring positions in our 3 high-level residential treatment programs that will actually assist people in accessing those resources after they leave residential treatment. And it's to sort of ease those transitions of care and make sure that people aren't falling through the cracks. And then finally, we're proposing what we're calling a pilot recovery campus, which would include recovery housing as well as treatment services, recovery services, as well as employment support services and other life skills support and training. So a more intensive sort of recovery housing situation for folks. So it's aimed to sort of address gaps in those transitions of care and to help people sort of facilitate their path to recovery. So this includes $500,000 of startup funding one time, and then $1 million for operation.
So could you, thank you, say how many beds, the $1 million for the re-engagement beds, how many beds that is?
We're proposing 15 beds.
Okay, which is the same as in the recovery campus. Also 15, right? Is that?
The recovery, I'm sorry, I thought you were asking about the recovery campus. The recovery campus is 15 beds. For the re-engagement beds, it'll be driven by demand because they're an existing residential treatment provider. They can sort of flex up and down as needed for those stabilization beds.
Is there an upper range that you're thinking it would be? I mean, are we talking 5, 10, 15? I have no
I would
idea.
imagine more like 5.
Okay,
But we'll have to see what the demand is.
okay. Thank you.
Mhm.
It strikes me that this committee is probably not super conversant in this arena. It's not your focus. So let me just take a second to provide perspective. Vermont is well known for its hub and spoke system. I think everybody understands that. That's the treatment system. And we've talked earlier about this sort of continuum of prevention, intervention, harm reduction, treatment, recovery. Substance use as a chronic disease that is subject to relapse like any chronic disease, diabetes, whatever. And this is a big part of the governor's overall public safety proposals, as he articulated in his budget speech. And part of the population to have substance use that is especially vulnerable to relapse and re-engagement with our judicial system is those involved in justice-involved situations. So we've looked at our entire system and said, where are the places we can do better? Where are the places where perhaps people can fall through the cracks? And so this aspect of the residential system that you heard about with stabilization beds, a very high time of vulnerability, because if somebody doesn't have a stabilization bed, they're just back in the thralls of addiction and what that brings with it. And then these transitions of care from different levels of the system to another, where you never want somebody to fall through the cracks because you support them there and they're going to have a highway to success, hopefully. So this is what this proposal is really trying to do, is shore up areas that we feel could be solidified better and strengthened. And really with that population in mind that I mentioned, that really do seem to have a high recidivism rate and need more support because they're in a very tough place and have a lot to juggle while they're trying to get better from their substance use issues. That's the end of our presentation.
That's it. Oh. There's one. Okay. Excellent, yeah.
Yeah, sure. There, one is, quick, the stabilization beds, if I'm remembering correctly, and looking, I wanted to listen to what you're saying, so I stopped looking on my computer for the copy, but did we not, appropriate $1 million for stabilization beds through the opioid settlement, fund last year?
Turns out we did not. And Deputy Commissioner, am I correct on that? She may have disappeared.
Chief.
Well, we can get back to.
Sure we
Oh, I'm admitting her, hang on. I can do that. Did I just?
I don't know. She's not on.
disappeared.
Oh, looks like she's here. She's back. I didn't know I could do that. Erin, can you tell if I admitted her?
I admitted her.
You did?
Just, it takes a minute.
Okay.
It's all right. I will. We can talk about that later. In terms of the recovery campus, has.
Oh, here she is. Ellie, the question was, did we appropriate $1 million last year for stabilization beds? And I thought we did not, but can you confirm that?
I believe that we had, I need to turn to Paul Daly, and I apologize, I got kicked out of the Zoom there for a minute. Paul, can you answer that question? Or I can follow up.
So we'll give him a minute to search that while the representative provides her next question, because it's on the recovery.
Yeah, so the recovery campus, has this been, has the design of this and your thinking about this been informed by conversations with the recovery housing providers in the community? And do you have I guess you'll put out an RFP for the Yeah.
You
Yep, so
predicted everything, but sure.
We put out an RFI, so a request for information, and that just closed about a week and a half ago to get sort of ideas and information from, our partners in the field. And so we will be issuing an RFP for that campus, and we'll see where there's community readiness and where the need is.
All right, thank you.
Mm-hmm.
Rep. LaRouche, you have a question?
So the $1 million for re-engagement beds, you said about 5 beds, approximately 5 beds.
Yeah, I think we'll have to see what the demand is. But like I said, it can scale up and down based on demand.
So they would get the money per use. It's not a grant of that, the whole amount of money to providers, no?
It would be, we would give a grant and then we would reimburse them.
So
Representative Bloomley?
Yeah.
It was a one-time appropriation in the 25 budget.
Yes. And so I'm assuming that this expands the, I mean, are those recovery beds being continued, or is this, you're just funding the same beds,
Stabilization beds.
stabilization beds?
Yeah, we're continuing to fund the stabilization bed.
Okay. All right, thank you.
so is it based on use, or is you're just flat giving them so much money?
No, it's based on use.
Thanks.
Okay. Rep. Yakavoni?
You mentioned previously, maybe half an hour ago, that this was a current services budget. Should I assume, is it safe for me to assume that any funding for AIDS that was spent budgeted in 25 is budgeted for 26?
Yes, state funding and special funding is
Same
level
service
funded.
providers. Okay. Thank you.
Any other questions? Well, I want to thank you all, 3 of you, very much for coming. It's always great to see you and hear what you're up to, and thanks for all the work you're doing to protect the health of Vermonters.
Thanks for hearing us out.
Thank you.
Let's see where we are. It's the Senate Committee on Finance. Why do I have the? Okay.
Thank you, Dr. Levine.
Why don't we?